Hi, everyone. Thanks for joining us today. My name is Dr. Brooke Messer, and I'm joined by my colleagues, Drs. Mitch Eibach and Travis Witt, and we're from Vance Thompson Vision. And we're here to talk to you with our Advanced Patient Care, an exclusive podcast series by Vance Thompson Vision. Our purpose is to keep you at the forefront of optometry field through dynamic insights, practical clinic tips, and engaging expert discussions. Join us on a journey of continuous learning and professional growth as we delve into the latest advancements in eye care. Our mission is clear: empower eye care providers with the knowledge and tools needed to provide exceptional patient care. At Advanced Patient Care, we are dedicated to elevating eye care one episode at a time. So with that, hey guys, thanks for joining me today.
Yeah, excited to be here.
Thanks for having me.
It was nice to see you all last week. We were together last week at a symposium in Bozeman, Montana. And so we don't always get to see each other very often, but it's always good to be together in person. But when we can't be together in person, it's nice to connect through virtual events like this. And so with that, I'm going to have you guys introduce yourself if you don't mind. Mitch, can you kick us off and tell us a little bit about where you practice and what you've been up to?
Yeah, Mitch Eibach. I'm an optometrist with Vance Thompson Vision in Sioux Falls, South Dakota. I also help coordinate our residency here in Sioux Falls, and I primarily work in cataracts, cornea, refractive surgery, glaucoma, and dry eye.
And I'm Travis Witt, work for Vance Thompson Vision in the Bozeman, Montana office. Similar to Mitch, worked through cornea, cataracts, and glaucoma with Dr. Swan.
Nice. And Mitch, you've been working with keratoconus for a long time and cross-linking. You participated in a residency program at Minnesota Eye Consultants. And were they doing the FDA clinical trial for cross-linking back then? Or how does that timeline fall into your care or your career within optometry?
Yeah, so I'm going to try not to date myself here, but my residency was a little bit before the FDA clinical trial, and so it wasn't quite there yet. But I was a sub-investigator here in the FDA clinical trials at Vance Thompson Vision. Just when I was first starting in Sioux Falls, we were finishing up some of patient enrollment for the FDA clinical trials for epi-off cross-linking. And so I've really gotten to see this now for 10 years of practice, seeing the results and the outcomes for patients. It's been fun.
I would agree that I think it's okay to date ourselves because I also was in practice, as I believe Travis was. We were all in practice before cross-linking was FDA approved. And so it's been really nice to have that option for our patients and really deliver the mindset or the reassurance that, hey, we now have something that can actually stabilize your condition rather than just, continuing to change, refractive corrections, whether it's in glasses and contacts. Travis, again, I think it's okay to date ourselves, but
You're gonna put me on the spot.
Estimate, approximately, like, what year do you think was your first ever keratoconus diagnosis?
That's a good question. It was actually before I graduated in optometry school. It was through one of my internal rotations at Pacific University down at the downtown Portland clinic, and had a 13, 14-year-old girl come in for a routine eye exam, had been referred over from an optometrist to look for keratoconus, and indeed that's what her diagnosis was. And so we went through, we didn't quite have all the contact lens technology that we have now, but kind of went through talking about hybrid contacts at that point for her. So that would have been 2007.
I was just thinking that, between the three of us, I will say we're all probably maybe less than 20 years in, but maybe more than 15 roughly, or just about 15. I think, Mitch, you're maybe just under that.
Yeah, I'm the young buck in this crew.
Yeah. But again, I think we have a lot of experience in managing and diagnosing keratoconus. And so hopefully today you can see some of our insights and some of the clues we use to diagnose keratoconus. Myself, I'm Brooke Messer. I practice in West Fargo, North Dakota under Dr. Mike Greenwood. And I've been managing keratoconus again since I was in my residency, which was in 2010. And so again, have seen a lot of keratoconus. And my training is primarily in specialty contact lenses. So I've learned a lot working under Dr. Greenwood the last many years. And so my piece of it is really on the vision rehabilitation side. So I've really enjoyed learning about all the new technology that we have in keratoconus diagnosis. And that kind of leads me into our first topic, which is detecting and diagnosing keratoconus. And, back when we were in optometry school, we didn't have access, or it was limited access to technology that allowed us to catch early keratoconus. And so this was something that we would see, we'd see these steep Ks, maybe a really big irregularity if we were doing retinoscopy or autokeratometry or something like that. And, even this one we wouldn't miss on a topography scan. Where now that we have access to new technology through being able to analyze the front and the back side of the corneal shape, we're looking to find more cases like this. This patient is still at risk for keratoconus, or maybe even you'd officially call it the diagnosis. We probably need a little bit more information, but, this eye has average Ks or even somewhat flat Ks centrally, and would be easily missed by, something like an autokeratometry finding. So again, we're going to dive into what technology now tells us about. And Mitch, could you tell me about the value of corneal tomography in your practice now and how it helps you make these diagnoses earlier and earlier in the disease state?
Yeah, I think that's a great intro, Brooke. And I think it's important to also recognize that a lot of our colleagues are still looking for clues for keratoconus and then maybe sending out for topography or tomography. I've done some work with different companies looking at the percentage of optometrists in the US that have a corneal topography, and it's definitely less than 50% of practicing optometrists have access to topography or tomography inside their four walls. And so these technologies are becoming more and more popular. I think a lot of our colleagues in industry and companies are working harder to put more diagnostic capabilities under one machine or under one technology so that you can do more things with kind of one piece of equipment. But corneal tomography, I think the big differentiator here is we're looking at the elevation of the cornea on both the front and back surface. So not only looking at the front elevation, which we commonly will say is a corneal topography with a P, corneal tomography gives us front elevation as well as back elevation. And there's lots of studies that show in many of our early keratoconus patients, it's really the back elevation or posterior cornea that will bulge or change first. It also gives us a global pachymetry map. That's the bottom left square on the scan if you're watching. And so kind of an early clue for some patients, not all, can be you start to see thinning of the corneal pachymetry outside of that dashed 3mm ring. And so this is another kind of finding where we're thinning. Remember, the corneal apex should be the thinnest pachymetry, but it's not in some of these patients with keratoconus.
Yeah, and that's a great segue into some of the new consensus again with the Delphi panels on, the redefinition of keratoconus. Back when we were in school, we primarily used the CLEC study, and not to discredit all the work they did, back then with the technology they have, the CLEC study is an amazing conglomeration of so much information around patients with keratoconus, and we still reference that information to this date. However, with advancing technology, the definition of keratoconus has changed. And like you were saying with global pachymetry and shape change, keratoconus is no longer considered a condition where the cornea is thinner than what it should be. It's more about the distribution of the corneal tissue, which we'll get into a little bit. And again, it's a posterior corneal ectasia. So you can't really diagnose keratoconus without seeing the backside of the cornea, and that's where it happens first. So we really need that tomographic scan to show us that ectasia beginning in the posterior cornea. It's a non-inflammatory condition, meaning that the corneal thinning doesn't happen from, call it like an autoimmune change or like a rheumatoid melt or something like that. So the thinning from keratoconus is considered non-inflammatory. And they say that true unilateral thinning does not exist because it's a collagen disorder. And so you can't have two different collagens between the two eyes. Both eyes have the same collagen. And so they consider keratoconus to be truly a bilateral condition. Travis, if you look at this scan here, would you call this keratoconus?
Yeah, absolutely.
And
I think there's enough irregularity from superior to inferior where, yes.
But let's look at the Ks now. Tell me about, these numbers. And when you look at K readings on somebody with keratoconus or, analyzing a pentacam scan, do you look at the Ks?
I do, but it's kind of an afterthought for me. I look primarily at the scan along with the elevation, posterior and anterior elevations. I think the deceiving, component here is if you didn't have the scan, if you were just looking at, an autorefractor or an autokeratometer where you'd get primarily just those central 3 millimeters of information, where you're going to see that this looks flat, right? This patient's going to read somewhere in that 40 to 41, where they're definitely not steep as far as what you would see in those scans. Autokeratometry, same thing. You'd have to look outside of that zone and look more into the periphery to see that there is some steeping, that there is irregularity here. And I think,
do you think a patient like this would have vision complaints?
I'll go first. I think there's definitely a potential this patient may not have any visual complaints, or may notice something very mild from a change standpoint. Maybe they don't correct to as sharp of a 20/20. There's such a wide variety of vision that patients come in with when we see pentacams and we see the topographies and the tomographies, where a patient's vision doesn't always match what we see in the scan, which is why I think it's very difficult, very challenging to diagnose patients with keratoconus. I think we are very blessed. I've worked, basically within the refractive world my entire career, and have always had access to corneal topography and corneal tomography. So very blessed to be able to have access to this and catch and early diagnose patients that otherwise would not have been seen.
And for those of you listening, just to describe the image that we're looking at, it's a topographic scan of a cornea with a very inferior base cone, and the max K is 45.1. So no point on this cornea would be considered steep. And so our point here is that keratoconus can have average keratometry findings. It's not always steep. And that's true of a study that was done by Stephen Greenstein and his crew and out on the East Coast. And they did a study on the correlation of refraction and findings of keratoconus when you look at SIM-Ks alone. So those are the numbers that you get from the central cornea, and that the diagnosis of keratoconus related to SIM-Ks only. They only correlate with an accurate diagnosis of keratoconus when you get into the advanced keratoconus. So again, you can't really rely on SIM-Ks alone when we're trying to detect keratoconus at an early stage. Next, I'm going to have Mitch talk to us about this corneal thickness map, which we call global pachymetry, so we can see the corneal thickness across the entire cornea. And there's definitely a thinning spot, but this patient's pachymetry on the map is 590 with a min-K of 583. And we also have access to look at the entire tomographic scan, which is obvious keratoconus. And so, Mitch, can you tell us about, how often do you see corneal scans that are definitely keratoconus, but their pack is not that thin?
Yeah, I think, you talked about the Delphi panel, and it doesn't have a definition of thinning anymore. And this is really impressive slide building, by the way. And so if you look at the top here, this is basically a tomography using 4 different scans here, and we've just blown up, or Brooke blew up, the pachymetry area. And so if you look at the other ones, you definitely say this is keratoconus, right? We have inferior steepening, we have bulging or protruding to the posterior float, but we have a pretty normal pachymetry. One thing I always say about pachymetry in regards to the cornea, whether it's something where the cornea is thickening, maybe like a corneal edema situation or a Fuchs dystrophy patient, or it's thinning, corneal melt, keratoconus, in a lot of our patients, we don't know where we started. And so if it's the first time that you're seeing this patient, maybe it is thinning, but it started at 610. And so we just don't know here, but this is definitely a situation where a patient, looking at the rest of the picture, has keratoconus, but has a thick corneal pachymetry rather than a thin. And so I think it's more common than we used to recognize.
Yeah, and again, it gets back to that abnormal distribution of corneal thickness from the thinnest point of the cornea to the thickest point of cornea. It happens very quickly rather than just the gradual change that a normal cornea has. And thankfully, in some of the instruments we have here, Advanced Thompson Vision, there's indices and there's irregular detectors that flag us when, hey, this cornea goes from thinner to pretty thick quite rapidly, and so it'll flag like, hey, this distribution of corneal tissue is abnormal. So we have extra tools to help us find that. Next, we're going to talk a little bit about this patient here. So in front of us, we have again, a 4-map scan from the pentacam, so we can see the axial map, we can see the front and the back shape of the cornea. Those are our elevation maps, and corneal pachymetry. And to be honest, it's a pretty unexciting map. Travis, what do you think?
Yeah, it looks fairly normal. He's a little thin, right? But
Yep.
again, that by itself isn't, enough to diagnose anything. He's slightly less than average, but the Ks look very symmetrical. You definitely don't see any inferior steepening. Anterior and posterior elevation maps look symmetrical. There's definitely nothing I would call a hot spot. So
Yep.
I think I would say this patient's got a normal cornea. He's a little thinner than average, but nothing outside of range.
Yeah, and just to fill in the blanks, he's a 25-year-old male, and he has aspirations to be in the Air Force. And so, but the problem is, the reason he was sent to us is that his left eye looks like this. What do you think now, Travis?
It's hard to believe that's how bad the left eye looks.
Yeah.
Obviously, there's pretty severe keratoconus on the left side. You can see that he's significantly thinner on the left side, down to 377, I believe is what it says. So he's 100 microns thinner in his left eye than his right, and obviously substantial steepening in the left eye. And so definitely enough to say left eye needs to be treated, and then it makes you rethink about what your plan is for the right eye, knowing that unilateral thinning doesn't exist. Unilateral keratoconus doesn't exist. It's a matter of time typically before the right eye undergoes those changes, and a heavy discussion and education with the patient about saying this is likely to happen in the right eye. It's just a matter of when, not if, and that treatment would be recommended to stabilize it as it is right now when it looks as good as it does.
Yeah. Mitch, do you have any comments to?
Yeah, I think the one variable here is I'm definitely not on the global consensus panel, and so I won't try to disagree 100%, but I have a fair amount of patients who actually look something similar to this, who have really unilateral aggressive eye rubbing on one side. And so this is a patient that I would talk heavily with about eye rubbing. I think it's the number one modifiable risk factor of keratoconus, and maybe that patient sleeps very commonly on their left side or kind of pillow dives, uses their hand while they're sleeping. Maybe they have some type of other pathology, allergic conjunctivitis, blepharitis, something that's causing itching more on the left side than the right. And so I have a fair amount of patients who actually have a distribution like this, maybe not to this extreme, but all that's going to make me do in the right eye is I'm probably not recommending treatment to stop disease progression before we even say this is keratoconus. I'm just going to watch this patient a little bit closer. And so I'm going to talk to them about the importance of not taking a 10-year hiatus from getting eye exams.
Yeah, it's this is a tough one, and I think we did end up cross-linking the right eye, and in this case there is no real wrong or right answer in the management. Cross-linking is safe and it's effective, and so in that case you can feel good about recommending it, but no procedure comes without risk. And so I agree with you, Mitch, in that, like, gosh, like, he's 2015, his cornea is so darn normal, other than being just a hint thin. Is it worth any risk? And this is a tough case. And again, like you said, I've seen a couple of these over the years too, where you see this, and like you said, education on eye rubbing is a big one here. And then careful and close monitoring based on his age. So now we've talked a little bit about detecting early and the importance of understanding that keratoconus can look differently on many different presentations. So now we're going to talk a little bit about management options for keratoconus, particularly in the way of stabilizing the disease and treating it with epithelium off corneal collagen cross-linking. Travis, will you talk me through, the cross-linking procedure and what happens to the cornea with treatment?
Yeah, of course. So I'll kind of walk you through how I talk to my patients about it. I tell them that the procedure itself is painless, that they're numb through the entire process. We gently remove the very outer surface, the epithelial layer from the cornea, basically just giving us access to allowing that riboflavin, that vitamin drop, to penetrate into the depth of the cornea. So the first half hour is where we're basically placing a drop of riboflavin, which is just a concentrated dose of vitamin B2, onto the cornea and allowing this to penetrate into the depth of the cornea. At which point then we use a specific wavelength of UV light that then targets that cornea and disperses light across it that lasts for another half hour, that then creates these bonds and allows that riboflavin to create covalent bonds within the cornea and bind to the rest of the collagen. Once the light's done, the procedure's over, they obviously have an epi defect at that point, and we place a soft bandage contact lens on the eye that stays in day and night for the patient, and typically takes about 4 or 5 days for that epithelial tissue to complete back to closure.
Yeah, perfect. Mitch, when you talk about patients who are eligible or indicated for cross-linking, who are you selecting and who do you identify as best candidates?
Yeah. And so in the FDA clinical trials, cross-linking was studied on patients age 14 to 65. I always will make the disclaimer that doesn't mean that we shouldn't cross-link a 12-year-old or a 9-year-old. That patient's at a much higher risk for progressing, but that is what we would call off-label. We do off-label stuff all the time. It's also, cross-linking was FDA approved for progressive keratoconus and refractive surgery ectasia. And so listed out here, Brooke, you have what the FDA definitions are. And I always tell my colleagues it's important to note that we're not doing anything wrong if we're cross-linking a patient who technically we haven't jumped through the hoops of progression for. In fact, if it was my 10-year-old child, that's what I would want. But insurance requirements for a lot of our insurance carriers do mandate progression, have some different definitions for that. And so a refraction change, a myopic spherical equivalent increase of greater than a half diopter, greater than 1 diopter astigmatic or cylinder increase in their glasses prescription, greater than 1 diopter Kmax or keratometry increase. And that can really be from any keratometry measurement. And so very commonly that will come from a auto K, and then now in our practice, maybe a tomography, and that can work. And then also a change in the back optical zone radius of curvature on a hard contact lens. And if I'm looking for that one, I call you Brooke.
Yes, and that's fine because I don't even look for that one that much anymore. You shared this case with me on what progressive keratoconus can look like. And so would you talk through your case for us?
Yeah, so this was a 17-year-old who came to see us in 2015. And so as Brooke mentioned at the onset, in the very early part of my career here in Sioux Falls, we were an enrollment site for the FDA clinical trial, but this was in between finishing enrollment for the FDA clinical trial and before FDA approval. And so this patient came to see us, and we didn't have an option for cross-linking. We're kind of in an in-between phase. On the left, you see the first tomography here. And so I think, hard to dispute that this is a keratoconic patient. We have anterior elevation or topographic changes in that top left map. We definitely have an underlying bulging to the posterior float. We have a thin corneal pachymetry. The inferior to superior ratio is 3.3. And so what we did with this patient is said, hey, we want to see you back in 4 to 6 months. Patient that came back probably 9 to 12 months later here, and this is what we had just 9 to 12 months later. And so steepening to Kmax, almost 5 diopters. We had further thinning to the pachymetry and worsening of that inferior to superior ratio, or the cone had advanced more. And so this was a patient who definitely qualified for progressive keratoconus here.
And when you're looking at progressive keratoconus and, how does age fit into the discussion of, are you progressing or not, or help you make the decision on whether or not to recommend cross-linking?
Yeah, I think it is a misconception or a miss to say because my patient is 45, they're not progressing, or they're 55, so they're not progressing, or even if they're 65, they're definitely not progressing, because I've seen progression in each of those 3 tiers in our practice. Now it's more in the 45-year-olds than it is in the 55-year-olds, and the least in the 65-year-olds. Cornea is one of the few spots in our body that actually strengthens over time. Our body creates these corneal crosslinks as we age, but it doesn't mean just because you have a certain number of candles on your birthday cake, you haven't progressed. And so we've cross-linked a 67-year-old here in Sioux Falls. She was an aggressive eye rubber, came in for cataract surgery, had a very minimal amount of lens change. We diagnosed her with keratoconus, and she said, my vision's been changing rapidly. And so we delayed doing cataract surgery, retested or remapped her 6 months, and there was definitely change. And so I don't think age is definitive.
Travis, have you ever seen a patient that has had epithelium off corneal cross-linking with the FDA-approved method that needed repeat cross-linking?
I have not with the epi-off study. I have with epi-on prior prior to the FDA's approval of cross-linking. We at my previous office in Denver had done non-FDA approved off-label epi-on, or kind of a hybrid of epi-on, epi-off cross-linking. And I've probably seen maybe 2-3 cases of that. I mean, we were doing that back in 2010. The studies, as far as what's shown how effective is cross-linking, have been out there for probably 20 years or so, as far as how long the rest of the world has had access to it. And those patients, the patients that had progression and we actually did a secondary treatment for patients that had more severe keratoconus, definitely thinner. They're more advanced on that scale, and they're in that 4 to 5 severity scale.
Mm-hmm.
And I told these patients, like, we're trying to do this to avoid a corneal transplant. And if it was my eye, this is what I would do. I would definitely do cross-linking. You definitely have a higher potential that maybe this is too far along and that we won't get that stability, that there's not going to be enough tissue within the cornea to stabilize it. But I've actually yet to see a patient progress with epi-off cross-linking. Or I'm sorry, yes, epi-off cross-linking.
Epi-off, yep. And I would agree with that. And so does the data. We recently had access to the 10-year results to the cross-linking pivotal trial. And as you can see in these here, across all patient populations, which includes keratoconus and post-LASIK ectasia, 84% of patients maintained or gained best spectacle visual acuity, with 100% of keratoconus patients maintaining their acuity or seeing better. And when it comes to keratoconus, when it comes to max keratometry findings in both the keratoconus and post-LASIK ectasia group, we see a nice chunk of these patients maintaining their corneal findings, if not have a little bit of flattening. Some of the patients in the FDA trial showed actually some max K flattening in the keratoconus group. So 81% or over 81% of our patients with keratoconus actually have stable or flatter max Ks 10 years after cross-linking. So again, your experience matches that data in that epithelium off cross-linking works. And I actually had a patient once ask me, like, if my collagen turns over and I get new fibers, like, do those bonds persist? And I think we can confidently tell our patients that, yeah, like 10 years post study, we still have some really good data around its continued stability. And so now we're going to talk a little bit about the patient post-op experience. And if Travis, I'm going to have you continue your discussion on how do patients do post-operatively?
Yeah. So I tell them, once you leave the clinic, you're probably not going to like us here for a few days. That we've created an epithelial defect. We've created a scratch on your cornea. We've done it with intention and with reason, but you're going to have light sensitivity, tearing, swelling, foreign body sensation. It's manageable. It's short term. Most patients after day 2, day 3 are starting to feel like they've turned the corner. And typically downtime is, in that kind of 3 to 4 day range. I tell them you can plan to go back to work after 4 or 5 days. But that the first few days, you're going to feel like kind of laying low and kind of managing that discomfort. Vision's definitely going to be blurry for the first handful of weeks, and that again, that epithelial remodeling process is important from a visual standpoint. So we're going to create more blur. These patients come in with a complaint of blur. They have keratoconus. That's why that's why they're in our chairs. That we're going to make it a little worse temporarily. But that over time, as that epithelial tissue remodels, as it tightens, vision can return back to its state. And that's where it's different patient to patient. I kind of tell them blur is expected for about 1 to 3 months. Most patients are feeling like they're getting kind of back to normal, close to that 3 to 4 week mark. And we're monitoring along the way for anyone who co-manages with corneal cross-linking. That kind of day 4 to day 5 visit is where we're looking at, is the epithelial tissue closed, removing that contact lens at that point. At that 1 month visit, you're looking for any potential corneal haze or scarring. Some of these patients can have a response to haze and may require an increased dosage of the steroid drop at that point, or kind of a longer taper with the steroid to reduce that, just to make sure that vision continues to improve. And typically by that kind of 3 to 6 month mark, patients are starting to find that kind of normalization of vision, and that this has a potential to change their prescription as well. So even though we're not doing any corneal reshaping like LASIK or PRK in conjunction with this, as those bonds are created, they can have small changes in their Ks and therefore small changes in prescription, and a new pair of glasses or new contacts could be pursued depending on kind of what the patient's wanting at that 3 to 6 month mark.
Yeah, long term, you're kind of just resuming that normal care, yearly topographies, continuing to counsel on eye rubbing, and, managing them refractively, whether it's glasses or contact lenses. And so thanks for that nice in-depth review. Travis mentioned epithelial remodeling after corneal cross-linking and how it can affect patients' refractive error. And they sometimes have to kind of hang in there for a little while so they can get back into their traditional methods of vision correction. I think the process of epithelial remodeling is really fascinating. Mitch, could you take us in on a little deep dive on how this happens and what it means for the patient experience?
Yeah, so with epi-off cross-linking, the surgeon's creating an 8 to 9 millimeter epi defect, and our epithelium is going to heal from the outside in. So from the limbus to the center, once those cells touch together, they kind of stack on top of each other. And so that's the epithelial remodeling. And so what I tell colleagues is if you do an anterior elevation map, like a topography at 3 months or sometimes even 6 months, it often looks worse. It looks like this patient's steepening, and it's actually just the epithelium is bunched up and kind of flattens back down over time.
Yeah, the epithelium actually masks the cone in the beginning. So it, kind of gets thicker at the base, thinner at the apex. So the cone actually looks less than what it truly is. And when that new epithelium grows back, it kind of grows back in a uniform thickness.
Mm-hmm.
And then, like you said, it kind of flattens at the apex and kind of hides the cone at the base. And this is a patient of mine that preoperatively, you can see his Kmax was 65.7. 6 months, he was still kind of struggling with his glasses and irregular astigmatism. And it would make sense because his Kmax had increased to 68.2. But then by 10 months, he actually came back down to that 65.2 Kmax. And he was finding himself, much more comfortable in his glasses and soft contact lenses, which we eventually fit into sclerals. But long story short is over the process, you actually see that epithelium reshape and kind of find that unique thickness across the corneal surface to help the patient get back to their sort of expected or normal refraction and level of irregular astigmatism. Mitch, I'm going to have you keep going with epithelium on cross-linking. We participated in the trial. I know you guys did. Travis, did you guys do epithelium on corneal cross-linking in Bozeman in the trial?
Yep, we did as well.
Okay, so all three of us have that, and being so it's still kind of investigational, we can't comment a lot, but I do think it's a great part of the future of keratoconus management. And so what are you guys looking forward to with epithelium on cross-linking being available to our patients in the future?
I'll start. I think it provides for sure a shorter procedure. Currently the Dresden protocol, what we do now with epithelium off just takes a long time. It's over 60 minutes for patients. It's 30 minutes of drops, 30 minutes of ultraviolet light with more drops. And so it takes a lot of time for patients. With this, hopefully we have a shorter procedure. And then second is the epithelium can stay intact. And now I don't want to mislead people because I bet your guys' experience is similar to mine. Some of these patients will still have an epithelial defect because you have to kind of try to loosen the tight junctions of the epithelium to get riboflavin dispersed through, and there's maybe a drying effect during the procedure. And so some of these patients still come back in. It is not the next day everyone's feeling perfect, and some of them still do have an epithelial defect, but better patient comfort is the second thing.
Yeah, I think it'll be interesting to see, how the epithelium remodels post cross-linking when it stays on the eye, if it needs to remodel at all. Travis, I think Mitch took all the good ones, but do you have anything to add?
Yeah, I mean, I would echo what Mitch says. I think for what we saw in the study, epithelium definitely looked a little more rough that first day or so. So it wasn't perfectly intact. It didn't look like an untouched cornea. And so we still tell patients, you're still going to have, the potential for some blurred vision. You definitely could still have some irritation for a day or two, but I think one of the big benefits is, vision returning to normal when you remove the entire epithelium and go through that whole remodeling process. Typically have a higher potential for post-op corneal haze, which not every patient goes through, but treating 3 to 6 months of haze is, there's a lot of hand holding in that with patients. I think there's a potential that you have less component of that, given that we're not removing epithelium, more so just kind of roughing it up a little bit.
Yeah, I agree. I agree with both of you. Some other future keratoconus management options, and these are more along the lines of vision rehabilitation to help us improve the patient's opportunity to get into maybe glasses and soft contact lenses, rather being committed to a scleral or a corneal gas perm. And I'll maybe jump into this a little bit, and then you guys can both add anything that you would like. The first one is called corneal tissue addition keratoplasty. So you might see some of these patients, depending on where you're listening from, you might be seeing, there are surgeons across the country doing this right now, so you might see a patient or two. And these are going to be patients that are maybe on the thinner side, moderate to advanced keratoconus. And it's actually similar in thought to Intacs. The problem with Intacs was that it wasn't very corneal compatible, and it created a lot of inflammation and neovascularization, and that it wasn't very customizable, where CTAC actually has a customized donor tissue. So it's a piece of a donor cornea that's been irradiated. So it's no longer living tissue. So it cannot reject, but it can be customized in the size, the thickness, the placement, all of that. So it's a much more customized treatment. The patient's individual pentacam images are analyzed, and then the surgeon gets this big report about where to place the tissue, how thick to make the laser channels and all of that. So it's just a very customized treatment with, again, the goal to improve the corneal surface for refractability. So again, these patients aren't looking for vision correction freedom. It's more just allowing them to have more options with better vision quality. And then second is topography guided PRK. For these are more of those mild moderate cases where there's maybe a little bit of tissue to give. We definitely don't want to go below that. We don't want to make the cornea too thin, but it's just kind of removing some tissue, or shifting the tissue in that it again allows for just more refractability, decreasing irregular astigmatism, so that patients can again get into glasses and contact lenses, maybe soft toric lenses. We probably wouldn't do this on an eye that isn't stable. We want these patients to be cross-linked first, so that we can feel comfortable about doing something like this with a laser. Do you guys have anything to add on these treatments? I think it's exciting for the future of keratoconus.
Yeah, I would say definitely exciting. I think the challenge in seeing patients with even mild to moderate, but seeing patients with keratoconus when they've had visual impact, they don't correct as well. Maybe they're intolerable to contact lenses, or they're a challenge for them, where we know contact lenses have a place in this paradigm to give patients best corrected vision. But the tough part is telling patients, when they come in, we're going to do a cross-linking procedure that's aimed at stabilizing the corneal tissue. It does not improve your vision. It doesn't make you more correctable. And so you're telling these patients, like, we're just trying to stop it from getting worse. And having potential advancements like these that give the potential of reducing irregularity, and kind of potentially normalizing that cornea to where these patients have a better possibility of refracting better, wearing glasses or soft contacts. Obviously very selective in who qualifies for these, but it's exciting.
Yeah, and our surgeons or Dr. Greenwood is particular about it as well. Like, we won't consider any of these things unless the patient basically proves to us that they're really struggling with their gas permeable contacts or their scleral lenses. And so the goal would try to be able to kind of simplify that into a soft lens or glasses. So again, it's not aimed at getting them out of correction. And I know you have a few patients that have had both of these things, Mitch. Anything to add to Travis's comments?
I don't think so. We're probably 15 to 20 CTAC patients in now here in Sioux Falls. We've combined this with ICL, or implantable Collamer lens, in a patient or two. We've combined this with cataract surgery in a patient or two, again, trying to just have a more normal corneal shape before going into some type of surgery. Topography guided PRK, we've done both with what's called the Athens protocol, where you do one first, then the other, back-to-back days. We've also done it where we've had a patient cross-linked first. Years down the road, we come back and try to do topography guided PRK. Again, rehabilitating the corneal, trying to normalize the anterior corneal shape to really get better vision. I think the big take home for me with both of these, Brooke, and you said it, is these are trying to get patients into glasses or soft lenses. And so the education that we give as their optometrist has to be much different. This is a situation where we want to overproduce and underpromise.
Yep, for sure. And so with that, let's talk a little bit about where contact lenses fit into the process with corneal cross-linking and keratoconus. And I'm going to kind of run with it, but you guys can certainly interrupt and add in some comments based on your experience as well. With soft lenses, basically, I recommend to patients that they can resume their soft contact lens wear after having corneal cross-linking done around 1 to 2 weeks. It's basically when you think the epithelium can handle the daily on and off removal of a soft contact lens. So maybe it depends on the age of the patient, how long they've been wearing contact lenses prior to this, any sort of dry eye findings that I'd be worried about disrupting the epithelium. But again, typically I stick to about 2 weeks. Depending on patient circumstance and experience. Scleral contact lenses, I also feel comfortable getting a current scleral lens wearer back into their scleral lenses around 2 weeks for established wearers. Again, these are patients that put the lenses in and take them out very comfortably, very confidently. New lens wearers, 1 to 3 months, depending on the severity of the cornea. What we would hate to do is start a new lens fit and then have them kind of change as they stabilize over 6 to 12 months and then ending up needing a change in their scleral lens. But, I used to stick to 3 months, where now I'm kind of shifting toward 1 month and not really having a lot of change. And so I would say now, about a 1 month start for new scleral lens wearers would be acceptable to me. Hybrid lenses and corneal gas perms, they interact with the corneal surface just a bit more. So I try and push to 1 month just to make sure I have plenty of epithelial shape change and healthy, fresh, sort of that non-fragile new epithelium, so that we can, appropriately apply and assess these lenses during the fitting process. One thing that I think is important to remember when it comes to contact lenses with patients who have keratoconus is that our contact lens technology nowadays, especially in scleral lenses, is so darn good that we can sometimes just assume the patient is doing well because they can see 20/20 in their scleral lens. They kind of forget that we kind of forget that, hey, this patient probably has reduced wearing time. They have to take their lens out earlier than maybe somebody who, has a normal cornea does. They have itchy eyes, they have irritated eyes, they have dry eyes. And so just because they seem to do well in their contacts, that we can pass the opportunity to treat with corneal cross-linking. Corneal cross-linking improves quality of life. It reduces the mental burden on patients with keratoconus. And so again, just because they're doing great in their scleral lens doesn't mean we can just go year to year to year, making those small power and contact lens adjustments to adapt to that corneal change. We don't manage any other disease like this. We don't let, cancer or high blood pressure or any other disease get a little bit worse before we actually refer for treatment. So again, just because they're doing well in contacts doesn't mean that they get a free pass on having corneal cross-linking done. In fact, there's data out there that says good best corrected visual acuity in patients with keratoconus, it actually is disproportionate to their quality of life. So patients can see really well, but they still feel like keratoconus significantly impacts their quality of life. So we can't base on how the patient's doing just on their correction in contact lenses. And even the CLEX study, somehow that got cut off on this slide here. But the CLEX study back in 2004, 10 years before we even had the opportunity to cross-link patients, they noted that clinicians who manage patients with keratoconus can be led into therapeutic complacency because the patient has good visual acuity in their contacts. And so again, just don't let yourself fall into that mindset that my patient's doing good for the 10 minutes I saw them this year. And so I'll just wait a whole nother year before I see them again. Again, the best thing to do for these patients, even if they're doing well in contacts, is to make sure to get them cross-linked. Just a couple of comments on new tech in contact lenses, particularly sclerals. We have scleral topography, which maps, out to 20 millimeters on the corneal surface and allows us to build a really customized contact lens, which is really nice. And for patients who come from a ways away, like sometimes they do in Fargo, serving some rural areas, it's nice to be able to just scan the cornea, get the image, get the lens made, and then have a lens that's nice, lock and key with this type of technology. Impression-based designs are also really fun to do. I had my impression done a few years back, and thankfully this third image is not my cornea, but you can see, even down to the sutures on this transplant here, how detailed those impressions can become. And then they basically use a 3D model to create a custom scleral lens with custom depths and curvatures and all of that. Many lenses nowadays, even the diagnostic fitting set base scleral lenses, have unique landing curves to vault over things like blebs and large pinguecula cysts and things like that. So just some good stuff to think about with corneal cross-linking and patients wearing contact lenses. To close, I just have a couple comments on how, we know so much more about keratoconus than we ever have before, and that has allowed us to change the way we diagnose and treat these patients. And thankfully, it's better than it's ever been before, and that we really should recognize that cross-linking is an essential treatment. Mitch, I'm going to have you wrap us up.
Yeah, thanks, Travis, Brooke. I think this was great. Hopefully we gave our colleagues pearls, tips, things to use in their practices to better take care of patients. And if this sparked interest in you, you want something more, we'd love to invite you to have a personalized mini fellowship here in our practice, whether it's with Travis in Bozeman or Brooke in Fargo or one of myself or my colleagues here in Sioux Falls. We'd love to have you come in, see some patients, hopefully immerse yourself in a hands-on experience, talking with our optometrists and ophthalmologists so that we can really better take care of the patients that are in our communities. Remember that eye care is ever evolving and changing, and so we're all kind of at really the tip of the spear to better take care of patients, and this is just something that we offer. We'd love to have you.
Thanks, everyone.